distinguished colleagues, oncologists, and researchers, Namaste. It is an honor to present at InterOnco. For centuries, traditional Chinese medicine has categorized hepatocellular carcinoma, HCC, under the syndrome of Shui Zhi, or blood stasis. Historically, this diagnosis relied on macroscopic signs, fixed abdominal masses, pain, and hemorrhagical changes. For the modern oncologist, these terms may seem archaic. However, we are now in the era of precision integration. Today, I propose that we reframe the concept of blood stasis not as a mystical energy blockage, but as a defined pathological state of the tumor microenvironment. It is characterized by hypercoagulability, microcirculatory impairment, and tumor hypoxia. The biological equivalent of this stasis is the thrombin, PAR1 axis. In HCC, the tumor actively exploits the coagulation cascade, specifically thrombin, to drive malignancy. My presentation today focuses on the traditional blood breaker Shui Zhi, known as Hirudin medicinalis, and its active polypeptide, Hirudin. We will explore how this potent thrombin inhibitor acts as a critical synergistic agent to prevent resistance to our standard of care treatment, Sorafenib. To understand the value of Hirudin, we must first acknowledge that thrombin is far more than a clotting factor. It is a potent mitogen. High concentrations of thrombin activate protease-activated receptor 1, or PAR1, expressed on cancer cells and platelets. Upon activation, PAR1 triggers a cascade that drives three critical processes. Proliferation, it pushes tumor cells into the growth phase. Inflammation, it creates the toxic heat characteristic of aggressive HCC. Vasculogenic mimicry, perhaps most dangerously, thrombin allows tumor cells to form their own blood channels, independent of normal vessels. Hirudin, the specific inhibitor. Enter Hirudin. It is the most potent, naturally occurring direct thrombin inhibitor known to pharmacology. By binding directly to thrombin, Hirudin does not merely anticoagulate, it severs the PAR1 signaling loop. In the language of traditional medicine, this breaks the stasis. In the language of molecular oncology, this is targeted signal transduction inhibition. This brings us to the clinical crux, Sorafenib resistance. Sorafenib effectively starves the tumor. However, this creates a selective pressure, tumor hypoxia. Under hypoxic stress, HCC cells stabilize HIF1 alpha. This factor then triggers a secondary wave of vessel growth that renders the tumor resistant to treatment. Here lies the unique contribution of Hirudin. Evidence indicates that Hirudin targets this exact resistance mechanism. First, it suppresses the expression of HIF1 alpha, disrupting the rescue pathway. Second, while Sorafenib attacks existing vessels, Hirudin shuts down the alternative supply routes, the vasculogenic mimicry that Sorafenib misses. Therefore, the combination is mechanically synergistic. Sorafenib attacks the supply, while Hirudin prevents the tumor's adaptation. In conclusion, the integrative bridge is about precision integration. When we diagnose a patient with HCC and blood stasis, we are identifying a thrombin-driven hypoxic phenotype. Treating this patient with Sorafenib alone addresses only half the equation. By integrating Hirudin, we are deploying a potent biologic agent that dismantles the stasis and prevents drug resistance. This is the future of oncology, where ancient observations guide us toward overlooked molecular targets. Moving to the evidence-based core of our protocol, between 2020 and 2025, the primary concern was drug-drug interaction. We can now confidently state that LDXGT maintains pharmacokinetic stability. It does not interfere with the CYP450 enzymatic pathways, meaning Sorafenib's bioavailability remains untouched. More importantly, we observe a parallel shield effect. While the TKI focuses on the tumor, LDXGT acts as a molecular buffer for the liver, significantly reducing transaminase spikes. For the patient, this translates into a higher quality of life, with fewer interruptions in their oncology treatment due to side effects like the hand-foot syndrome. In conclusion, distinguished colleagues, our approach is not a departure from modern oncology, but an evolution of it. By integrating Shui Zhi, and LDXGT, we are implementing a twofold strategy, a dual hit on the tumor's survival mechanisms, and a parallel shield for the patient's hepatic health. We have shown that we can break the blood stasis, or the thrombin-driven resistance, without compromising the pharmacology of Sorafenib. This is what we call precision integration. It is a bridge between ancient clinical wisdom and modern molecular targets, designed to move our patients beyond simple survival toward true oncological optimization. Thank you for your attention, and I look forward to our collaboration in advancing these integrative frontiers.